although there may well be in the future. This is the algorithm that we are referring to. This is what we proposed in Lancet Respiratory Medicine, led by Daryl Abrams a couple of years ago, whereby after providing the basic care, treating the underlying disease, providing lung protective ventilation, if the PDEF ratio is less than 150, we strongly recommend prone positioning. And then there are other potential recommendations. But if you, at that point, meet Eolia criteria and there's no contraindication, that's when we would provide ECMO, both in non-COVID-19 as well as COVID-19 related ARDS. Early data has started to inform our approach, and this is from the early Paris experience by Mathieu Schmidt and Alain Combe from the Paris-Sorbonne University Hospital Network. That's 5 ICUs in Paris. This is their first 83 patients. And you can see here what's called a stacked bar plot, showing outcomes and estimated probabilities of mortality when patients are still in the ICU or in the hospital and we don't have final outcomes. And this is, we've done this many times in the pandemic as we push out data for the community. So here are patients with good outcomes. These are all patients who started on ECMO, almost no one on ECMO by the end of the study period, patients who are alive and out of the ICU, patients who had died down here, and then some patients who were in the ICU at the time of reporting, so we don't really know their outcome. There was an estimated 31% probability of day 60 mortality and 36% probability of day 90 mortality. They updated their data, this by Guillaume Le Breton, Pascal Leprince, also from Paris, and now reporting on what was called the Greater Paris ECMO Network Organization. 17 ICUs throughout Paris that coordinated their efforts throughout the pandemic, organized very early on. This is their experience from the beginning of March to the beginning of June last year, where they centrally regulated all of their processes and agreed on ECMO indications. And that was very helpful to the centers who were referring patients and to those centers who were receiving them. They pooled resources between the centers and created 5 additional mobile ECMO teams so that they had 6 in total to call on. And this just gives you a sense of the level of organization that they created, which was very impressive. They had 302 ECMO patients with a median age of 52. More than half of them were transferred by mobile ECMO. They reported a higher mortality at 54%. And this gives you a sense of what factors might have accounted for some of that mortality. This is a volume outcome relationship that they demonstrated. If you'd done at least 30 cases of ECMO in the prior years compared with fewer than 30. Here, and we'll see this throughout, that age is a major risk factor for mortality. Less than or equal to 48 did much better than, for instance, 49 to 56 or older. And then days between endotracheal intubation and initiation of ECMO, if it was fewer than 3, you did better than if it was more than that. And then, of course, there's the Chilean experience that most of you are, I'm sure, familiar with. This is from Rodrigo Diaz and colleagues in the American Journal of Respiratory and Critical Care Medicine. This is the nationwide Chilean cohort, also a very organized effort, very impressive, reporting on the experience from the beginning of March through the end of August last year, linking national databases to identify 94 patients who received ECMO, 85 of them looked at in a very careful retrospective analysis. And I'd say that the most important thing to point out here, and the most impressive, is that 92% of patients received prone positioning prior to ECMO. And if we go back to 2016, in the publication of the LungSafe study, when even patients with a PDEF ratio less than 100 only had received prone positioning in 16.3% of the cases across almost 500 ICUs throughout the world, that it's incredibly impressive that 92% during a crisis received that. And I think we're seeing more and more prone positioning throughout the world as COVID has engaged all of us in the importance of that. Neuromuscular blockade was provided in most patients, the great majority VV ECMO, and a third of them were transferred by mobile ECMO. The 90-day mortality in this study, very similar to the early Paris experience at 38.8%, with hospital length of stay, again, similar to what we've seen elsewhere, very long, 50 days, and ICU length of stay at 40 days. What about complications? It's what we'd expect to see. Hospital-acquired infections, ventilator-associated pneumonia, bleeding, oxygenator failure, thromboembolic disease led the way. This is the US experience from the Stop COVID investigators reporting in intensive care medicine. So 190 COVID-19 patients from 35 hospitals. And they did what's called an emulated target trial, essentially using observational data through statistical manipulation to emulate a randomized controlled trial, in this case of ECMO versus no ECMO, for those patients within 7 days of ECMO with a generous PDEF of less than 100. They were able to show here in the unadjusted survival curves, mortality with ECMO was 34.6%, mortality without ECMO, 47.4%, very similar to what we saw in the Eolia trial. And then a couple of studies from the international experience, this from the Euro also, where Roberto LaRusso and Jan Bolovic led the way for a survey study of centers that were both ELSO and non-ELSO centers throughout Europe. Here reporting in intensive care medicine on the patients from March 15th through September 14th, 1,531 patients in this study from 177 centers throughout Europe, showing a relatively similar mortality of 45%. And then there's the paper from the ELSO registry, this from the Lancet last year. I want to point out my colleagues, Ryan Barbaro, Graham McLaren, and Phil Boonstra, who did tremendous work on this. Ryan, obviously the head of the registry committee for ELSO. And I'd like to commend the rest of the ELSO registry committee for having created an addendum for COVID-19 that was very powerful for us in terms of analyzing this data. This is now the first 1,035 COVID-19 patients in the registry from 213 centers across 36 countries. We can see that the estimated cumulative incidence of in-hospital mortality, this is 90 days after initiating Ecmo, was 37.4%. Here again, the stacked bar plot with those patients with good outcomes, acute rehab or home. Here are patients who died. These are the few patients left who were hospitalized, censored patients where we didn't have their data. And here are the patients who were either discharged from the Ecmo center to another hospital or to a long-term acute care facility. Complications in this study, if we look at COVID-19 complications compared to those in the ELSO registry in the year prior, you can see there were higher rates of CNS hemorrhage, membrane lung failure, circuit clot, and circuit change. If you then normalize for the number of hours of ECMO, knowing that these COVID patients are on for longer and suggesting they might just be accumulating complications, you actually see that normalized for the number of hours, there's really no difference between the groups, suggesting that the increase in complications was mostly due to an increase in amount of time on ECMO. However, this is observational data, and we cannot account for differences in practice, for instance, increased levels of anticoagulation that might account for this similarity. What factors were associated with in-hospital mortality? Age was very strongly associated. This is 40s, increasing risk with 50s, 60s, and then 70 or more. Immunocompromised status, chronic respiratory disease, if you had a cardiac arrest prior to ECMO, acute kidney injury, or if you were started on VA or VBA as compared with initially on VV, you had a higher risk of mortality. I want to show you one outlier. This is the German experience from Christian Karagiannides and colleagues, published recently in the American Journal of Respiratory and Critical Care Medicine as a letter. This is in Germany, 768 patients from February into December, mean age of 58, 78% men, but they had a higher in-hospital mortality than we've seen in the other cohorts at 73%. Again, age very strongly associated with mortality, as was the amount of time on mechanical ventilation, with 0 to 3 days being better. So why such a high mortality? We really don't have answers, because this is very high-level data from, it's about a third of the German population from one of their insurance companies. But it's important to note that there, for the most part, were not resource restrictions in Germany for the majority of ICUs. The median age was higher than in other studies at 58, yet even the youngest patients had higher mortality than we're seeing. So that remains to be explained why there was higher mortality in a country with such sophisticated ECMO and ICU care. What about a different approach? Many of you may have seen this letter in JAMA Surgery from Asif Mustafa and colleagues from the United States. These are their first 40 COVID-19 ARDS patients met Eolia criteria. And a lot has been made of the fact that they use the Protect Duo cannula, double lumen cannula from the right atrium to the pulmonary artery. It's a double lumen cannula that provides either right ventricular assist support or can be used for ECMO. But they also use many other interventions, including direct thrombin inhibitors, high-dose glucocorticoids, even before the recovery trial was published, and at higher doses, inhaled nitric oxide, and they aim to extubate and mobilize their patients. This is now the follow-up letter that they published with complete reporting on all patients. They showed a mortality overall of 17.5%. Again, a small population, but very good outcomes. And we're just beginning to tease apart what might have resulted in such good outcomes, and something to keep an eye on. In putting it all together, this is now looking at the data from the early experience in the pandemic. This is Dr. Ramanathan leading us in a systematic review and meta-analysis in critical care, 22 observational studies, 1,900 patients, the vast majority of VV ECMO. And you can see that the pooled in-hospital mortality was 37.1%. So of course, very heavily weighted towards the 1,035 patients in the also registry study, but similar mortality to across those studies, except for the exceptions that I showed you that we were seeing in the first waves of the pandemic. So the question is that the final answer? Is that the outcome data that we have? And the answer to that is there's been a lot of data since what we would call the early waves. And I'm not going to define first or second or third wave because that depends on where you are in the world. But if you look at the initial experience versus later waves, you begin to see a pattern. And this is data from Spain and Portugal, recently published as a letter in intensive care medicine. This is from the Ecmo study group looking at retrospectively 24 Ecmo centers, 22 in Spain and 2 in Portugal. 319 Ecmo patients, about half in what they call the first wave, March through end of June last year, as compared with the second wave, July through the beginning of December. And you can see here that the survival went from 59% to 40%. So actually got worse from the first wave to what they call the second. Euroless also looked at their data again. Mike Broman led this effort in Lancet Respiratory Medicine. They also created first versus second waves with survival decreasing from 53 down to 44% in the second wave. The Paris-Sorbonne group under Mathieu Schmidt, again, looked at their data in the first and second wave, and once again showed that survival had decreased. Here, seeing mortality in the second wave, 48% as compared with the earlier mortality of 36%. So in all of these experiences showing worsening outcomes over time. And we had seen that when we looked at the live ELSO registry dashboard here, an example of from a few weeks ago. When we first published in the Lancet, the mortality from the registry was 37.4%, but last fall we noticed 48, 49, 50, 51%, and realized that we had to look back at the data because outcomes were evolving. And so this was round 2, looking at the first 4,812 patients, here from 349 centers across 41 countries. There were 3 groups that we looked at. The original group, those who'd received Ecmo or been initiated on it as of May 1st of last year, and those at the same centers that went on, to put patients on Ecmo after May 1st. So just comparing at the same centers what happened in the early wave versus later, and then in a third group looking at those who hadn't put anyone on through May 1st. We call them late adopting centers. And the answer is that the mortality was very similar in the initial group. This is very similar data. It's just a little bit more data now. But it was 15% higher, absolute higher mortality in the same centers providing Ecmo later in the pandemic, as we were seeing a signal of in the other studies. And of course, even higher mortality in those who had not put patients on early in the pandemic, the late adopting centers. The risk factors for mortality in the study were similar to the first ELSO registry study. And the real question is, why are the outcomes getting worse? Why over time are they worse rather than better now that we have more experience? One of the obvious answers would be that as we become more confident, we're putting sicker patients on Ecmo, but we actually saw the opposite. So in the first wave patients in the ELSO registry study, we saw that they had a higher apparent risk of mortality when risk adjusted, not a lower one. So they should have actually had a higher mortality initially instead of a lower mortality. And our hypotheses going into it were twofold. One, that that over time around the world, there was more use of non-invasive ventilation, both helmet and mask ventilation, as well as high flow ventilation. Once the risk of aerosolization was understood to be not as high as we felt at the beginning of the pandemic. And so with that increased risk, those patients who failed, it may not be bad across a population of patients, but those patients who end up failing non-invasive are the ones who would have higher work of breathing towards the time that they're failing. And so it might create patient self-inflicted lung injury, might have worse lung injury by the time they're actually on the vent or on ECMO, thereby having more refractory disease. And we did in fact see that there was more use of non-invasive. We don't know how many days of use, it's just not in the data. We also postulated that increased use of corticosteroids over time would then select for those who are only steroid refractory over time. And we did, of course, see increased use of corticosteroids. Here in the summary slide, we show that the ECMO was 20 days rather than 14, 6 days longer in the later cohort, and a 15% higher mortality rate, which means that when we consider allocating resources, we really need to consider both of those factors, and we need to continue to watch the evolution of these outcomes over time. So what is the role of ECMO in COVID-19 related ARDS? This is the third of three of the ELSO guidance documents that we've put out, this led by Janelle Badalak in the SIO journal, where we suggest that we should continue to follow current evidence, titrate ECMO use based on capacity and outcomes, and really important to coordinate within countries and regions, as was done in Paris and Chile, also having been done in the United Kingdom and a variety of other places throughout the world, as we think that can benefit outcomes. Here, for those who are interested in that paper, is an algorithm suggesting how to approach ECMO as resources become more scarce, whether conventional capacity, contingency capacity, tier 1 or 2, or crisis capacity conditions. So in terms of the use of ECMO during COVID-19, in conclusion, I would say that it's part of the ARDS algorithm and should continue to be so. Outcomes are clearly evolving. We need to follow that as time goes along, and more evidence is obviously needed. And what's very good is that a lot more evidence will be coming. Thank you very much for your time and attention.